Hi, welcome to the episode 3 of season 2 Ask Giri the Physio Show. Your host Giri Srinivasan. Today we're going to talk about pain, brain and dim sims. So obviously we're going to discuss about pain and how the brain takes care of the pain, and dim sim is a secret we're going to talk about later. This is kind of, you can say it's a kind of a subsequent episode after the Pain 101 we did last year. You can go check it out in the physioshow.ca website. This is kind of sequel to that. Little more information about how brain handles pain and how we perceive pain, and why brain is the boss. And we're going to talk about it now. What is the goal? What is the vision? Why we need to talk about this? Our vision here is, you see in the slide there, all Canadians should have the knowledge, which is the most powerful thing and most underutilized thing, and the skills and support to prevent and also overcome the chronic pain or the persistent pain or any kind of pain. So that is the vision. That is why we are spending a lot of time in educating and empowering the community members about pain and how they should go about it, right? So I want to kind of send my gratitude and my thanks and to my two pain gurus, I would call it. They are great scientists, pain scientists and researchers, and also they teach in universities, and I personally attended their seminars and workshops and in different international conferences I go to in all over the world. And that's Lorimer Moisley, the guy on the right hand side you see without specs, and Dave Butler, the guy with the fantastic green glasses. They've written so many books and articles and so many conference presentations, very into pain and how to manage pain, and a lot of RCTs and peer-reviewed journals and articles, which so much interest to. So during this presentation, I'm going to bring in lots of bits of information, all research, evidence-based information to you guys, and proposed and talked about and done by these two scientists. I'm just the messenger. I'm not the creator of all the information we're going to discuss here. So all credit goes to these two guys you see here in the picture. So pain. First, before we go into the pain, we have to understand what is the biopsychosocial model of pain. Okay, it's not just you poke a pin here, the tissue damage, and that gives you pain, and that's what you feel it. It's not like that. And as I told you in my previous episodes, that whatever we have studied about pain in school, it's all changed here, right? The most advanced research and the medical outcome in these days are two things. One is the genome, the genetic mapping. The another one is brain mapping. We know much more about our brain now than what we did before. So that's what kind of makes this pain education and the pain science much more understandable and much more easy to explain to the public, right? So what is biopsychosocial model of pain? So as you see in the chart there, you see how many factors are affecting the pain, how you feel the pain in your body, right? It's not just the tissue damage. You see the physical, which is your danger signals coming from different parts of the body, and you can see other factors like, environmental factors like financial issues, cultural beliefs, social issues, and also lack of health insurance, a lack of benefits, mortgage going up. There's so many factors can affect your pain as well. We'll discuss more later how mortgage going up is going to affect my pain. Yes, it does. Psychosocial relationships with your work, with your family, and are you depressed? Are you isolated? In this pandemic era, if you're single, you're working from home, you're not even stepping out of the house unless you go for kind of grocery shopping or something like that. How's your social life? Are you meeting your best friends for a kind of good laugh? Things like that. And psychological factors. How's your mood? How's your concentration? What do you do for fun? And how's your personality trait? Anxiety. So all those things matters when you talk about pain. It's not just the tissue damage. We're going to talk about it in more detail. I'll give you a couple more seconds for you guys to kind of go through that slide, because people have given me feedback that I change my slides very quick. So I'm going to give you a couple of seconds there. Good. So let's move on. The next thing what we're going to talk about is the pain buffer zone. right? So how is our buffer zone before injury, and what happens to the buffer zone after injury? David Butler calls this a twin peak analogy in his books, but we're going to talk about that. So as you see in the picture, before your injury, and you're a very active guy, you like to go for a run, you like to go for trekking, and you climb mountains and all those things. At that time, your pain trigger line is pretty high up in here, right? It takes a lot for you to feel pain. And also the buffer zone between the pain trigger line and if you see the actual damage line, it's very small, very small. It's not a big buffer zone there at all. So that's how you live your life. Suddenly one day when you go for a run, you twist your ankle, you hurt your ligaments, you're swollen, red, pain, and then what happens, right? You try to go through that and everything. Once you develop so many pain neurotags in the brain, we'll talk about neurotags later. And then slowly, if you experience pain for a long time, the buffer zone increases. You see in the next diagram there, how much the gap increases between your pain trigger line and your actual damage line. The more the buffer, you're going to have more protection in your brain. All more neurons are going to be taken care of. Danger, danger, danger. It's going to tell you all the time. So it's important to understand that pain buffer zone and what we can do to reduce the buffer zone as it was before the injury. So the next one is message is pain is more sophisticated protective device. That's all it is. Pain is basically a protective mechanism, right? When you get hurt and information, the signal goes to the brain. It's up to the brain to understand and see if is it worth having pain or not. It's not up to your tissue. And it'll decide and it'll say, oh, pain. Okay, this guy hurt his foot. Let's protect that, give him some pain and protect that foot so that he doesn't run anymore after injuring his ankle or strain his ligament. So it's basically a protective mechanism. And if the protection information is staying longer in your brain, then that is a problem leading into chronic pain. So, next one. So, as we talked about, it protects your body tissues. Anything that suggests you need protecting takes the pain up. Anything you suggest that you don't takes the pain down. So, we'll talk about that protectometer later as David Butler explains. Anything you keep on thinking, oh, my back is very fragile, it's very painful, I should not be bending down, I should be protecting my back. So that information, it can take your pain up, right? Oh, back is stiff, yeah, I have a little pain when I bend, but what if I work through that pain while bending? That takes the pain down. So that's how the brain works, right? A lot of time when we describe this to the patients, they're like, oh, this is not my case. I actually have a bulged disc where the pain coming from. My disc, I saw in the MRI, doctor told me, he pointed out the disc and told me the disc is bulged and the things are coming out and putting pressure on my nerve, right? Actually, disc itself it's not an appropriate term to call disc as a disc. It's never a disc shape at all, right? So what is the right name for the disc? We call it LAFT. It's a living, adaptable force transducer, right? That is what disc is. It is not just a gel comes out and things. Is very adaptable. It's very living. When things comes out, they die. So they don't sit on your nerve and compress your nerves all the time. When the disc substance comes out and it touches your nerve, yes, it gives you a lot of pain. Pain is real. I'm not saying no, but that does not sit on your nerve all the time. It dies and falls off. Your scavenger cells will come and eat them off. So don't think if you have disc prolapse, that's going to sit on it for the rest of your life, giving you shooting pain into the legs. No, that's not true. So you learned something today new. Disc is actually not a disc. It's actually living, adaptable force transducer. You learned something. LAFT. Okay. Okay. Next thing is, so they also did a lot of experiment. The violinist, they felt much more pain and more sensitive to pain when their left finger is hurt compared to the right finger, because it is their finger which they use a lot for string, right? For the violinist compared to this hand. So this is a proven research. Why? Because they know this finger is much more important to them. Their brain knows this finger is much more important to them than this. That's why any small injury happens to this finger, they are much more sensitive to pain and other information. That makes you think like, how the brain works. And pain is not equal to damage. I always reinforce this statement in most of my presentation and to my patient education when they come into that. This is the important thing patients like you have to know. Pain is not equal to damage. Okay. Tissue damage is neither sufficient nor necessary for pain. I've told an example in a previous presentation about this. A guy in England, right, a construction worker, and a nail went through his boots and he was screaming in pain, agonizing pain. The co-workers took him to the hospital, to the emergency. They give him so much painkillers and morphine doses and everything. He was screaming in the emergency department. Then when they opened the shoe carefully, they noticed the nail actually didn't go through his foot. It went between his toes. It didn't even damage his tissues. It's actually, the true thing happened, it's actually a research paper. So you wonder why you are screaming in pain. Just the sight of the nail going through the foot, through the shoe, that's what gave him the pain. There was no actual tissue damage at all. This is a great example for you to understand pain doesn't equal to tissue damage. And when Moisley correctly says, the evidence that tissue pathology does not explain chronic pain is overwhelming. There's so much evidence out there. But how much do you know? How much your healthcare practitioners is discussing that with you as a patient? How much education is happening? When you go to a family physician or your healthcare practitioner about pain, how much pain education is happening? How soon we jump on your knee pain? Oh, your knee is hurting, wear and tear, bone on bone. How soon we are jumping on that and making you feel that it's end of the world, right? Our language, our communication has to change. That's very important. We have to be very sensitive about what words we use when we are talking to our patients, because that goes in very deeply in the brain. Because pain doesn't associate it with an object, right? For example, coffee means smell. What pain associates with? Nothing. So pain always looks for something to associate with. So if I say, oh, you have bone on your knee, boom, pain jumps on, catches that word. Bone on bone, bone on bone, bone on bone. Every time I feel a little tickle in my knee, oh, my physiotherapist told me bone on bone. My God, bone on bone, right? That's what you have to be very careful what language you use when you speak to your patients. And that really, really very important. The metaphors we use, we talk about later in there. So, and the next valuable point you need to know is pain depends on how much danger your brain thinks you are in, not how much danger you're actually in. Again, as I said, your brain is your boss, not your tissues, not your joint, not your nerve. Actually, you might be very appalled when I say there is nothing like joint pain, muscle pain, or nerve pain. As most of the advertisements make you feel, oh, joint pain, muscle pain, nerve pain. It's basically a danger signals coming from your body. It's up to your brain to perceive where it hurts and how it should hurt. Okay, so that's something we'll talk about in detail later. Okay, so the longer you have pain, the better your system gets to producing it. So that is where the chronic pain problems come in. Right? You start with anti-inflammatories. Any injury happens, first line of defense, anti-inflammatories, painkillers. If the pain doesn't go down, go back to the doctor, little bit heavier dose of painkillers. Doesn't happen, go back again, little more heavier, naproxen, oxytocin, patches. If that doesn't stop, okay, shall we inject that joint to relieve the pain? Shall we kill the nerves? Shall we burn the nerves? Well, let's see if that, we will keep on injecting every 2 months and then let's see if that kills your pain. We think that tissue is what giving you so much pain, so we're going to kill that tissue or kill the supply to the tissue so that you don't have pain. Is that a good approach? Oh, 3-4 injections, you didn't shut up, you're still saying you're pain. Okay, let's take it out. Let's go in and take it out. Take out the tissue or alter it or trim it or put a knot on it. Is that going to solve the problem? These are the questions you have to ask yourself. Educate yourself. Look into the research. Then you'll understand. So the longer you have pain, your tissues are more protected. Then even a small danger signal can be amplified for you. So that's what brain does very well. And brain uses all the incoming data from everywhere, from your joints, your muscles, from your eyes, the smell, the hearing, the temperature, the touch, the mood, who you're with, where you're at, everything matters. That's all matters in the pain neurotag. And your brain is like a jungle, right? We believe before, brain is full of neurons, neuron cells and everything. And then now we know that the neuronal cells, the neurons in the brain is much less than the immune cells. Brain is actually an immune body, not just a neuronal body, right? There are more immune cells in your brain than the neuron cells. What's the function of the immune cells? To keep you safe. Immune cells know very well who you are. When you are not you, immune cells go crazy. They'll be hyperprotective. They send so much signals to you to feel it. So when you're injured, you're not you. That's when immune cells go, boom, danger, 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 danger. So understand that brain is more immune cells than neuron cells. And the immune cells do produce things which has to be in balance. If the balances goes up, you feel more pain. No pain, less pain. So it's you can control that balance from your immune cells. It's a neuroimmune circuit. And we'll talk about neurotags. So you see all the connections between different parts of the brain. When you're in pain, not one center activates in your brain. Brain activates almost 400 to 500 centers in your brain. When we were in school before, okay, pain pathway, tissue damage, pain goes up, spinal cord, thalamus projecting to the brain, and then we thought about some cortical area, just one cortical area, that's where the brain pain kind of projecting. That's not true. You activate 400 to 500 areas in your brain. They speak to each other, right? Hey, I am the movement guy. I feel some movement here. Should I feel pain? Then it connects to the eyes. Oh, where is he? Oh, he's at work. This is the place he always feel pain. Yes, maybe you should give him some pain. Then the vision center communicates to the hearing center. What does he hear? Is it too noisy at the workplace? Whenever it's too noisy, he feels more pain. Or whenever his coworker is screaming at the phone, he feels more pain. Okay, that's a message. Okay, I get that in one. Then what kind of smell is there in the office? And the other one, emotion. Oh, did he fight with his wife in the morning before he came to office? Then the other side, what about the recent phone call he had from the bank that his interest rates are going up for his mortgage? All this information, they talk to each other and the brain comes together and then thinks, is it worth having pain? Is it worth giving him pain at this point of time? Oh yeah, yes, all this thing, yes, let's give him pain. So that's how the pain neurotag works. The neurotag is basically a circuit. They compete for influences from each other, right? When neurotags turn on, they do something. It's up to them what they want to do, right? It's not up to you, but you can control. And pain emerges with activation of the pain neurotag. We just talk about this example right now. We just discussed that. Hope you understand how it works. It's never one thing. It's so many things activates to make you feel brain. Okay. Only if the brain thinks it's worth to give you pain at this point of time. And the next thing we're going to talk about the beautiful medicine cabinet or drug cabinet in your brain, how that works. And that pharmacy is open 24/7, and this pharmacy in your brain is free of charge, no side effects, no parking fees, and then you can activate, no prescription needed, you can activate those drugs whenever you want to. Let's talk about it. I'm going to use the whiteboard and I'm going to explain to you how the drug cabinet opens and closes in your brain and how you can control it to give yourself a free, powerful medication with no side effect. Okay, so this is the brain here. So we all have a great medicine cabinet in our brain. I'm just going to draw a little box here. Okay, that's our medicine cabinet. Okay. This medicine cabinet has very powerful painkillers or opioids in there. And there is cortisol, oxytocin, morphine, serotonin. There's so many things will be secreted here by our neuroimmune mechanism. Okay, these powerful medications, they drip down into your spinal cord. It can go out to the system there, and also it goes out to the different areas of the brain. Okay. We have so many different centers of the brain. It's all connected, as we talked about neurotags already. They're all connected. So it also goes through that Neurotags in there. Okay. So what is the function of this, our own pharmacy, our drug cabinet? When a danger signal comes from, it's too cold, too hot, nociceptive signals, a danger signal of pain, any signal comes in, this will take care of that pain right here, or that signal right here. It's not worth sending these signals to the brain, then you don't perceive any pain. Okay. For example, a small paper cut, the signal comes in, danger, danger, danger. I want to inform the brain, hey brain, danger. Then these pain medications, which you're secreting by yourself, will say, no, it is not worth for him to have this pain or this signal to travel up there. It's not worth for the brain to give him pain right now. He's busy working on this thing. This paper cut is not going to harmful. I don't have to protect him. It just blocks right here. The no danger signal goes up. It is not going from here for your thalamus right here. It's a main relay center. It goes to thalamus, and thalamus shouts out to everyone, hey, there's a small paper cut. No worries, he's good. Okay, there is no pain. Right? That is how these medications, your own pharmacy, helps you in blocking those danger signals coming up to the brain. Okay. These signals not only coming from here, it also comes from here. Sometimes, what you see, what you hear, what you smell, they also comes, and then these opioids in here will block that information too. Hey, it's not a big deal. It's a little bad smell, but it's okay. You don't have to feel anything about it. Okay. So the brain is the final deciding factor to find out, is it worth having pain now? For example, you are crossing a busy street. You kind of trip your ankle and you got hurt. And the cars are coming in. Are you going to stand there in the middle of the road and take care of your ankle, or are you going to just quickly cross even though you hurt your ankle? You will cross the road. You won't stop in the middle of the road when the trucks are coming on the other side. Your brain decides, is it worth having pain right now when he's going to cross the road? Or he has to cross the road, then we will make him feel the pain. Same thing. When the footballer running 30 seconds before you finish the game, is very close to the goal post, he can hit the goal and he had very severe back spasm. Is he going to stop? Or he's going to finish that goal? Brain thinks it's not worth having pain at that time. It won't give him pain. He will put the goal, he will enjoy the success, then he might have pain after that. So that is how pain plays it. So understand your drug cabinet, understand how it works. Now the next question is, where is the key? How do you open and close this drug cabinet? Okay, what is the key to open this and close the drug cabinet? We're going to discuss that now. Okay, I hope you understand this. So respect your own pharmacy. You can activate that, it's free. Okay, we'll go to the next one. We can move the board now. Okay, key. How do we open and close the medicine cabinet? The answer is dim sim. Welcome to the world of dim sim. Are you hungry? I love dim sims, by the way. I love Chinese food. So, what is dim? What is sim? Dim means the dangers in me. What I think, what I believe as the dangers in me is dims. What I believe the safety in me is sims. So, D for danger, S for safety. Okay. So, we're going to talk about how that is a key to open that medicine cabinet. It's interesting, isn't it? Let's go look at it. So, I have this picture. It's a lot of information in there. The next one, we'll explain that about it. It's kind of a busy slide. Again, this is based on David Butler's knowledge of dim sims here. You see in the middle, what are the things which can alter, which can open and close that medicine cabinet we talked about? The things you hear, you see, you smell, you taste, you touch, everything affects. Sometimes that just smell of the dental clinic can increase your pain in the jaw and the teeth. Believe me, yeah, it does. Things you do, right? What are the things you do that can increase or decrease your pain level? And what you believe in it. Things you say. If you keep saying, Oh, I'm getting really old. I have my grandma's knees. Right? It's your own knees. It's not your grandma's knees. And you just keep saying that metaphor, and you develop a neurotag for that, and you develop a signature in your brain for that metaphor. And every time you use the word, it's going to activate the pain. Oh, my back goes out all the time. I need someone to put it back in. Where does your back go out? For a vacation? That kind of metaphors is very bad, because you develop that signature in your brain that your back goes out every time you get a little pain. Oh my God, my back is out. And you're going to imagine this, something is coming out of each other and it's staying like this and somebody has to put it back in. It never happens. Unless a truck runs over you, right? If your back goes out, you will be in ICU with the morphine drips. You won't be walking into the clinic for treatment. So things you say really affects. The places you go, that affects. People you're with, when you're in a good buddy and you're laughing, having a beer with the buddy, you're going to feel a lot of pain at that time. Or when you're very stressed at work, you will feel more pain. That makes a difference, right? And also things happening to your body. So these are the things, how you think about it. What are the dangers you're thinking about it? Oh my God, I saw that x-ray. It's degeneration. My doctor told me there's a degeneration of L5. That's what's causing me. Degeneration is a normal thing. It's a normal phenomenon. It doesn't have to give you pain. So things you see, things you say, things you hear from your physicians, family or friends or Dr. Google or YouTube, that makes a difference. So we have to reduce the danger signals by the way we feel danger, think, feel, hear, and increase the safety in me. Yeah, I have a little cracking sound when I move. Doesn't matter. Doesn't bother me. I'm going to do the squats anyway. Right? That's a safety in me approach. We're going to talk about it more. So you be a sim hunter. That's what I want you to be, not a dim hunter. I want you to be a sim hunter. Okay. So we call it as a protectometer. Again, David Butler's book, they call this protectometer. And the protectometer going from the top, danger, then safety. How you can move up and move down, just the way you think it is, how danger it is. It's in your hands to move that protectometer higher up or lower down by the way you activate your dims and sims. So more dim, you feel a lot of pain. More sim, you feel less pain. So you can alter that. So you have to check your backpack for how much of dims you have in your backpack. The common things we hear in the clinic is like, very negative attitude about your condition. Oh, it's never going to get better. I have seen so many healthcare practitioners, so many physios and chiros and injections and medications. It never got better. It's never going to get better. That attitude does not going to help. Fear of movement. Oh, if I bend, my disc is going to come out more and it's going to hurt me. No, there is no evidence. High sugar food, fried foods, very bad sleep patterns, no enough rest, no plans for your treatment. You just keep chasing the pain, putting a band-aid on one over the other. There is no hope given to you. Everybody is dooming. Everybody is giving you dims wherever you go. Because dims are advertised more than sims, right? Because they have to sell a product or a service. So the dims are more advertised. That's why you see dims everywhere, but not sims. No hope, lack of fitness, low expectations, right? So these are things you have to come out of. And how to be a good sim hunter, you have to go after this. Fitness and mobility, move. Yes, people with pain will have more pain when they move. I'm not saying no. Go through that barrier. Yes, I know I will have pain when I move for the first few days. Then I'm going to get better. There's a light at the end of the tunnel. I'm going towards it. I have a good support, good coach with me. My physiotherapist is going to help me to get there. I believe in him. I trust in him. I trust the process. There is evidence for this. Let's go through this. That's what you need. The patience, not like a couple of treatments. Oh, my pain is more now. When you ask me to do the exercises, I did it. It's more pain now. It's not good. I'm done. I'm giving up. No, have some patience and perseverance. You will get there. We will get you there. Right? We understand your pain. It's real. But there's a way to approach it. Supportive friends and a good coach. Like we are physiotherapists, we see ourselves as a coach, not a clinician. Coach who helps you in a healthy living, not just your joint pain or knee pain. Wholesome food, warm clothes, detailed plans, a treatment plan, a clarity in your mind goes a long way. Hope and inspiration from your whole healthcare team, from your family members, and very positive attitude. This is what we need, right? That's why we listen to the patients when they use those metaphors in the clinic, and we immediately talk to them about it. We immediately kind of tell them it's not right. Even people say, oh, my bad leg. Even my neurological patients say, oh, my stroke side, my bad leg. I always correct them. Do not say it's a bad leg. Say it's a right leg. When you say bad leg, you're creating the bad leg signature in your brain. It always going to tell you that it's a bad leg. It's not going to get better. It's not going to get better. It's right leg. It's not your bad leg. Right? So what to do now? Okay, Giri, you told me all these things. You tell me everything is the brain. It's not my tissue. You're telling it's not my Achilles tendon. It's not my lower back. You must be crazy. It takes some time for you to believe me. I won't be surprised if you, oh my God, this is not me. This guy is crazy. He's telling me my pain is in the brain. I've heard it before. Take your time. Don't get offended. Don't get bombarded. Just take your time. Relax and understand, assimilate the information I'm giving you. This is not just me. It's a scientist research, proven research. It's evidence. We have evidence for every single sentence we said that here. Okay, I'm not just coming out of the bushes and saying, oh, this is what I want you to believe in. No, it's not the case. So what to do now? What you can do? You rethink pain. You ask yourself, what is my belief about my pain? What do I know about the pain I have? So based on the information I have here, what Giri has given me, how I can rethink my pain. Is it a specific place when I go to I feel more pain? Is it the specific person I am with I feel more pain? Is it a specific thinking pattern I have more pain? So what is my belief? What is my attitude? Ask yourself that question. And understand your amazing protector meter and how your sims and dims can alter that. And re-engage with your system to retrain it. That's very important. Teach your brain to be less protective. Tell them it's okay to move. Tell them it's okay to bend. Tell them it's okay to lift. Tell them it's okay to squat. You're not going to hurt your knee more if you squat. And understand, tell your brain good things like Sims. Motion is lotion. Movement is medicine. I'm going to move more. Even though there's a little bit of pain, I'm going to move more. I know it's good for me. Right? Break those beliefs. Get a good coach. The coach can be a physiotherapist or a chiropractor or your doctor or your friend or your family member, anybody. Get a good coach who knows pain science, right? Who's not throwing you dims all the time. Who is a kind of a sim hunter too and who knows pain science, right? And start your journey again. Restart it, right? And recover well. That's what I wish for you, all of you, right? Now we'll go into that audience question and we'll talk about it. So Daniel from Edmonton asked me, what are the right questions to ask for my general practitioners or physiotherapists about my pain? What to ask them? What's the right questions to ask? I put some examples here for you, Daniel. So ask your healthcare practitioners, your doctor or physio or chiro, whatever it is. Ask these questions. How do I know if my pain system is being overprotective? How do I identify that? How do I retrain my pain system to be less protective? Right? And how do I know I'm safe to move? These are the questions you need to ask your physicians, not give me more painkillers. Oh, this painkiller is not working. Give me more powerful painkillers. Oh, none of the painkillers working. Let's go for injection. That's not the right way, right approach. Our opioid crisis is very bad in our province, in our country. The depression levels are so much opioid crisis. Means the pandemic didn't help us at all. This is the path for us to go. Prepare more pain educators, send them out to the community, educate this to the people. That's the only way you can bring that problem down. Education, right? So the next question actually, next question is from, I'm going too much. Yes, Jesse. Jesse from Edmonton asked, what is the missing link in our pain management system in Alberta? As I just told you, the missing link is the contemporary pain education. Alberta Health Services, the health department, the health ministry, the health minister has to put some thoughts and some planning committee to start a pain education program. Educate, create more pain educators with this kind of information and go out there and educate the public so they can understand and they have better equipments and tools to handle the pain without going down the paths of the drugs and the opioids and stuff like that. I know pharmacies and drug companies going to hate me, but I'm sorry. I'm for the people. I need to tell them the truth, the pain science, the research, the evidence, the sims. You guys can keep bombarding DIMS. I'll try to bombard the sims as much as I can so that they can take the informed decision. And as what's the best treatment and prevention sometimes makes no sense to people because it's so simple. You're telling me I can open the powerful medicine cabinet in my brain by just the way I think? You must be kidding me. I'm spending $1,000 a month for the pain medications. Yeah. And you have to understand why they hurt, so that the hurt will be very less for you. If you don't understand, then you'll be hurting more. I hope you got some information, something to think about, something to ponder about, something to ask yourself the right questions. And you can sit down and write down what are the things really your triggers, your dims in you. You write down what are the dims for you and what are the sims for you. And then see how you can change your protectometer from taking away the dims from your life and adding more sims to your life. I wish you well for adding more sims to your life. Thank you so much for your attention. And if you want to watch any of my previous episodes, it's all archived in physioshow.ca. You can visit that. And we have YouTube channel and Facebook live channel. Give your feedbacks, give your comments. Tell me what I can do better. Tell me if you like it or what you don't like it. I'm very open for feedbacks and love to educate and empower you more and more and more to come. Have a great day. Have a great week. Again, be a sim hunter. Bye.